Okay, so this is the lecture that we're going to have for people who are not able to actually have the full lecture on cerebrovascular. It is
So learning objectives, we're going to quickly
we
talk
are going
about
to
some concepts
have
of blood flow
test
impairment,
number 2, which
ischemic
for some
stroke,
of you
and
will be
hemorrhagic
on
stroke.
Monday. And in particular, when we talk about hemorrhagic stroke, there's only going to be really two types of strokes that we're going to talk about. Actually one that's the most important, which is this thing called arrhythmial subarachnoid hemorrhage, or SAH. And we will talk briefly about something called AVMs, which are arterial malformations. This is something that more commonly happens in pediatric populations, and really not something you have to be too worried about in the adult populations. So very quickly looking, all this basically is some pictures and junk I took off of the internet and flipped them around and recolored them. And what this is to give you an example of, and this is a concept of what we call what I call flow impairment. Okay, I'm taking this isn't, you don't have to have this cited anywhere else. This is my own concept that I use for learning, and it's one that you guys should consider as well. If we look at this right here, this is an artery that is feeding tissues. These little puff balls right here are arteries. Are tissues, or our target tissues that we want to perfuse. Okay, so these are target tissues. This is your arterial supply that is coming down, and notice that it branches off. You have main branches like this, and then you have these little branches that come off. Notice if we were to follow this one main branch right here, all the way down to where it ends, it sort of finishes off just in this tissue area right here. And if we were to block this off, you obviously would not get any blood flow here. Now take a close look right next door to it, where the pointer is pointing. Look, there is this other branch coming off of this other artery over here that is sort of feeding generally in the same area. We call this collateral circulation. So this is something you have to keep in mind, because as we talked about when we talked about MI, and when we talk about cerebrovascular disorders as well, in particular strokes is what we're talking about here, we have to keep in mind that there are these things called collateral circulation that will keep portions or areas around where there is a decreased flow alive for an extended period of time. You have, in most situations, you will have one area which is not getting any blood supply, but around that area, it will be a graduated amount of, or a layered level of perfusion that is occurring. Sort of like in the dead center in the middle here, where this main branch is going, yes, there is going to be some tissue that will have no tissue flow. But because of this little branch coming down over here, and maybe some other branches coming up from some other arteries over here, some of the tissue surrounding it might actually get some blood flow, not 100%, but the tissue surrounding it will get some blood flow that will keep it alive, or extend the time it has to stay alive longer than coming right off the main branch. That is something to keep in mind. Now, having said that, how much area that is going to be damaged, you can imagine that if you looked at, we go back to the same little area here, if we just put a little blockage right over here on this little artery here, we're not going to have a very big area that is having a lot of occlusion to it. But if we were to move our blockage up here and block off this route right here, not only is this area blocked off and all the branches it serves, but also this branch right here won't have any blood flow, and all the little branches that come off of it and all the tissue it serves would be blocked off, so that you would have a larger area of what we would call an area that has 100% infarct, or 100% loss of blood. And you would still have area around it that would get some blood flow, or a graduated amount. Maybe it only has 60 or 70% reduction of blood flow. The further you go away from the core that has got 100% loss of blood flow, you will see graduations of maybe 50% blood loss, maybe only 40%, then 30%, and onwards and onwards until you've gotten into, you're back to 100% blood flow into tissue. So this is where I've said in class, it's like looking at a target where the bullseye in the middle is got completely 100% blood flow loss, but as you go out in each concentric ring, then you have less and less blood flow loss. The outermost rings of a target would have very close to 100% blood flow and would not die as quickly. But the closer you move into that bullseye of that target, where there is 100% blood flow, you get more, or 100% blood flow blockage. You get more and more and more as you move into that center, an increasing amount of blood flow loss, and stuff closest to the target will dry quicker than the stuff going out. And we typically say that when you have a complete blockage where there is 100% loss of blood flow to one area, that tissue is the main area of the infarct, and that tissue will most likely die. The key here is to reperfuse quickly, like similar in MI as we talk about in cerebrovascular. The key here is to try and reduce the amount of tissue that will die by reperfusing tissue as quickly as possible. Those areas outside of the target outside of the bullseye, outside of the bullseye, we are trying to get that tissue to survive. Okay, and there are two ways that we can have loss of blood flow to an area. We can have an obstruction, like we have right here, basically a dam. And notice I've even changed the cover here, the color here. So a lot of this tissue is ischemic. The term ischemic means not perfused. Okay, there is going to be a misnomer here, and otherwise a name that doesn't make sense as we are going along here. We know what the term ischemic means. Ischemic means loss of blood flow, and when we have an obstruction, we have a loss of blood flow. And notice I didn't totally, with these tissues over here, completely make them black. There's a few areas over here that are still orangish, pinkish, purplish over here, or sorry, orangish or reddish over here. And the reason I did that is because they're probably getting some collateral blood flow from some other areas. So in this example, we have a very big central core of necrotic death going on here. But we could still potentially save some of this area over here because it's still getting a little bit of collateral blood flow. So that is what we are trying to save. If we do nothing, then what is most likely to happen is all of these tissues, even the areas that are partially orange, will die as well. And that's what we are trying to prevent. Okay. Now the other way we can do this is we could have a hemorrhage that is reducing blood flow as well. Notice the same concept. We have a lack of blood flow here. We're going to find out that hemorrhages that actually have a double whammy effect in here as opposed to a obstruction. But notice we still have one thing here. We still have ischemia happening, or these tissues, as we would describe them, have gone ischemic. Okay, in both a hemorrhagic event or an obstructive event, there is still ischemic tissue. Okay, where the misnomer comes in is that in a obstructive event, they tend to call it an ischemic stroke. Why? Well, we'll see why in the next couple of slides. But what they pretty much did is they thought, at a period of time, they thought all strokes were caused by a blockage. So they just called it an ischemic stroke, and they assumed it all, 99 to 100% of them always happened because of a clot. So they just assumed that that would occur. But now, as we are getting to know more and more, we know that it's not always the case. So the misnomer is that for an obstructive stroke, they call it, in the general terms, an ischemic stroke. So when you put ischemic in front of the word stroke, put those two things in brackets, or sorry, put those two things in, not in brackets, but in quotation marks. An ischemic stroke is referring to a obstruction occurring. A hemorrhagic stroke, in quotation marks, is referring to a stroke where you have ischemic tissue happening due to a bleed happening up here, where blood is pouring out of the artery into another area of the brain and not getting down here to the target tissues, and these tissues become ischemic. But as I said, if you see the term ischemic stroke, those two words together means an obstruction. It's a misnomer. It doesn't make sense. Why don't you just say hemorrhagic stroke ischemic stroke, or ischemic stroke, obstructive stroke. Well, that's not the way they named it. Okay, so that is what you have to deal with when you're reading the common literature that is out there. An ischemic, I'll say it one last time, an ischemic stroke in quotation marks means that a clot has occurred. A hemorrhagic stroke means that a broken blood vessel has occurred and blood is not flowing to the target tissues because the blood is pouring out into a different area and not reaching all the way down the artery system. So those are the two things you have to remember when you're looking at terms on the internet in your textbooks. That's how they will refer to it. But in both situations, the target tissue becomes ischemic. Okay, I know it's hard. Wrap your brain around a little bit about it, but I've already told you there is a misnomer there happening. So when we talk about flow impairment, I'm not going to go over these too much, but because these are more for your information as you're going through the lecture and as you're going through your readings. Tissue perfusion basically means a delivery of blood flow to certain areas. So if we say we are not perfused, we are not getting blood pouring over that target tissue that we want. An aneurysm is what we call a bulging or widening. It's usually due to a weakening that occurs within the arterial walls, and you end up getting a bulging that happens, and usually it ends up being because it's bulging and thinned out that it's more likely to rupture or burst and rupture, causing a bleed. Ischemia, as we said, as I've just sort of said, it's meaning constricting or holding back of blood flow. So if you look at that term right near, an abnormally low amount of blood flow can occur because of a clot, or which is, quote, ischemic stroke, or it could be due to a hemorrhagic stroke, which means that blood in both situations is not getting into them. So make sure that you understand which is which. An embolism is this one is a little bit different. This is a blockage or occlusion that forms from a blood clot or some other foreign particle or abnormal particle from the body moves through the circulation. It basically means piece or patch or something, and it can block off blood flow. We can see this with, for example, a embolism that caused from a clot. We can see a bunch of platelets that have all formed together, as I've told you guys about. Having atrial fibrillation, you can shoot off a blood clot that can be an embolism that actually either leads to a stroke, leads to an ischemic stroke in your head, or it can shoot over to the pulmonary into the pulmonary circulation. It would be known as a pulmonary embolism. In both situations, it would stop blood flow to a set of target tissues. In one situation, the brain; the other situation, the lungs. The other thing that can cause an embolism too is we can see that, and most commonly when we talk about fractures, we can see that you can have fat embolisms, you can have air embolisms that can stop blood flow. Yes, air running through tissues can actually block off blood flow. And any other sort of thing that you decide you want to inject into your bloodstream or gets into your bloodstream can actually be called an embolism. We see that the term emboli or embolus is just a general term that says something foreign and or clot in the bloodstream, and then you would give it an adjective saying it's a pulmonary embolism that is due to a blood clot. You will see that they say it's a fat embolism due to fat tissue that has leaked into the bloodstream from the bones. Things like that, there would be an adjective in front of the word embolism to actually describe what is going on. Okay, so you don't have this pretty picture in there, but this is called, when we call a stroke, they used to call it a brain attack. So hence my illustration here of the brain being attacked. This would be your brain. This would be your brain being attacked by a stroke. The etiology of a stroke, we usually see that when we have a stroke, there's some acute focal neurological deficit that will happen because of the vascular impairment that will occur. And as I said, it will be due to lack of tissue perfusion or ischemia that is occurring. And depending on how long this event occurs, it can be permanent or it can be acute, meaning it resolves. There's really only one type of stroke that we're going to talk about where you end up having a complete recovery from having the stroke. Most of the other ones will leave some sort of permanent deficit that needs to be overcome through rehabilitation, or which may not be overcome at all. And as I said, the two named types of stroke we will talk about is an ischemic stroke, meaning a clot or something is obstructing it, and you will have a hemorrhagic stroke, which means one where there is a burst or a ruptured blood vessel. So if we look at this on a diagram right here, we see that, look, if we say that these two circles right here are representative of this piece of artery right here in the brain, you can see that we can stop blood flow from going down here to this tissue through one of two ways. We can put a blockage right in there, an embolism, clot, whatever you want to call it. Some sort of blockage can block that off. This tissue will become ischemic. We can rupture this blood vessel right here and have blood flow where it's not supposed to, all around the brain, not getting to where it's supposed to at all. That means that it's going to not get down here. This tissue will become ischemic as well. So ischemic stroke, or an obstruction occurring with the blood vessel. We see the risk factors for this are age in every way, and every day I'm getting closer to a stroke. We see that gender is also a key point right here. Don't know why, but guys, we seem to be number one on the stroke list. Family history, if you've got a family history of this. Hypertension, sickle cell disease, and atrial fibrillation are ones where these ones up here, age, gender, race, family history, all of those you cannot really change whatsoever. There's no way to modify them. When we start here with hypertension, you can modify your hypertension risk factors. You can modify cigarette smoking. Diabetes mellitus, yes, you can modify diabetes mellitus. Then there's no, I know you're thinking, wait a minute, diabetes is something you have and you can never cure it. But in today's practice of treating diabetes, you have very well-controlled diabetics and you have very poor controlled diabetics. Diabetics who have very tight control have a very small increase, or can have a reasonably small increase in their overall risk factors. And then you compare that well-controlled diabetic to somebody who is poorly controlled in their diabetes, the risk factors increase incredibly. Somebody who has poor diabetic control, higher risk factors for atherosclerosis, stroke, and everything. So we do say that having diabetes does not give you a fixed risk factor, a fixed increased risk factor. Having diabetes itself does increase your risk factor, small to marginal, but if you are poorly controlled diabetic with the things we have in place today to control blood sugars, then you could increase your risk factors immensely by being poorly controlled. So we do see that diabetes is a modifiable risk factor. Asymptomatic carotid stenosis. This is where you actually have too much atherosclerosis in your carotid arteries and you have no symptoms until one of them breaks or ruptures. Sickle cell disease increases your risk factors quite significantly. It has some it can be modified, but just having sickle cell disease on its own increases your risk factor by quite a large amount. Hyperlipidemia, we can actually control that. That's modifiable. And atrial fibrillation, not modifiable. Well, with some medications you could say yes, you could modify it, but it does bring you for an increased risk just by having it. Okay, so I've just told you the modifiable versus non-modifiable risk factors. Ischemic stroke, caused by a cerebrovascular obstruction, a thrombus, or some sort of other foreign matter emboli. And this is why, think of it. This is why people thought, hey, all strokes in your brain are happening due to an obstruction, so let's just call it ischemic stroke. Because 87% of all strokes, that's like 13% away from 100. That's a pretty big number. It accounts for close to 90% of all strokes. Five main mechanisms for stroke subtypes where you will see these strokes happen. We see large artery atherosclerotic disease, so those carotid arteries leading up to the brain if they have atherosclerosis in them. Small vessel or penetrating artery disease. We'll have something called cardiogenic emboli. This happens because of blood clots that are created due to irregular heartbeats or irregular heart rhythms. And then we have this other one called cryptogenic and unusual causes. these ones are basically, these are not the two main ones that I would have big tests on you for. The first three are the most important. These ones are just make up a very small percentage of what's actually going on. Basically 4 and 5 means something that is unusual or something that just happens without us knowing. Now if we look at this diagram right here, I know you don't have it, but pay attention to why this is up on the screen right now. So we have a clot happening. Look at the major arteries leading up into the brain, okay, through your carotid arteries right here, coming up, feeding blood flow, and the other one on the other side here. If you were to put a blockage into one of those big main arteries, you end up having a huge area of brain. Actually, if you were to block it off down here, you pretty much would block off the entire one side of the brain, okay? In this situation here, we still have this large vessel. This is the carotid artery coming up here, coming through here, getting into those into the circle of Willis and those middle cerebral arteries. We get into this still large artery here. If we have a stroke and one of these major arteries leading in here, then you're going to have a relatively big area like this one here that is affected. If the stroke happens because one of these small, look at these little branches coming off here, we call these the small penetrating arteries that come off of the large artery, okay? If a stroke happens in there, you're going to have or a blockage happens in there, you're going to have a relatively smaller area of stroke, okay? And this is where we can see that if you're going to give me a stroke, which most of you usually do when you come up to my office after a pathology exam, so when you are having a stroke, if you tell me which one you're going to have, I'd rather have a small penetrating one. Why? Because it's a smaller area of my brain being affected when it's a small penetrating stroke. The problem is these ones are a little bit harder to get through any sort of mechanical surgical intervention. Okay, so yeah, a penetrating artery only basically screws up a smaller area, but the problem is that these small penetrating arteries are harder to get to and to fix. If you think about it, which portion of this artery right here, let's look at the other side here, which portion of this artery right here would be the easiest for a surgeon to get to? Here? No, you'd have to go through a lot of brain tissue to get there. Up in here? No, you'd just have to go through all this brain tissue to get to it for a surgical technique. Over here? Maybe, getting closer. Would it be really easy to get to a blood vessel sitting on the outside of your brain? Yeah, we just take your skull off and then go through there and play with it. And so for a direct surgical route fixing something, any artery, and they're small, but they're smaller than the main ones, but any artery out here on the top of the brain, very easy to get to and fix. I'm telling you this for a reason until we get to another slide, and I'll point that out. These large major arteries right here, you could probably get to the ones in the carotid arteries very well, but once it gets into here underneath the brain, it gets much more difficult. There are some techniques that you can use to try and balloon dilation that they can use to open up those areas. Okay. Ischemic, or what we call the penumbra. Oh my God, yes, a big fancy word. For some reason, as I said in class the other day, I don't know why, probably because brain surgeons deal with strokes and stuff like this, they have to give themselves a fancy freaking name for stuff. So, similar to what I talked about, the idea of a target, okay, where you have the bullseye has lost the core of the blood flow, and then everything around it has a graduated loss of blood flow. In any sort of neurovascular or stroke event, we call this phenomenon where the core has loss of blood flow and the rest has graduated loss of blood flow, the area that is not the bullseye, everything outside of that target bullseye is called the penumbra. Don't ask me why they asked for to do this silly name. That's what they came up with. Okay? If you're the researcher that came up with it and discovered it, hell, you can name it after yourself. So we could have the Smith area or whatever. So they named it the penumbra. Okay? So as I said, the evolution of that stroke revolves around that central core, that central part of the target, which is the bullseye, which has lost tissue. You've had a stroke, that tissue in the center is going to die. It didn't get any blood flow. Then there's cells around it going from the bullseye. The second ring from the bullseye out is then what we call graduated or ischemic tissue, and the further and further you go away from the bullseye, the more blood flow you have. Our core or our root area of trying to get you reperfused is to save those cells outside of the bullseye, which is called the penumbra, and try and save it from actually dying. This is a time-dependent thing that is going on. The longer you wait, the longer you do not reperfuse, the greater the chances of more of the tissue that is in the penumbra dying. Okay, the core or the center of the bullseye is going to die no matter what. Now you're in a race of time to try and prevent any further damage happening because of that clot. So those cells that are outside of the core will suffer the following. They will suffer impairment of metabolic activity. The longer they go without full oxygenation, the more impaired metabolic activity that will go on. Then that will lead to electrical failure, and that electrical failure would also lead to basically the cells dying. Structural integrity has to be maintained. The cells pop, blow up, do whatever. They die because of all these other, because of the impaired blood flow and impaired metabolic activity. So the cell's survival depends on, as I said, that adequate circulation. So getting the circulation back quickly, and then the volume of toxic products that are released during the time that they did not have adequate circulation, and also cerebral edema and blood flow that is occurring. So we have to get these things back to normal. These are all the dependent factors that must be taken into account of why tissue will continue to die outside of the core of the target. Those cells that are in that penumbra, and just to give you an idea, they remain viable for several hours afterwards. So even 1 or 2 hours after a stroke, you can get those tissues back, or a good portion of them. Exactly how many and how much? Well, that was the previous slide saying these all things have to be taken into factor. So this is where we try to get try and get that tissue back as quickly as possible. And the reason why it's able to do that is and why it stays alive is, again, because of that thing I told you about collateral circulation. Cells the cell depends on adequate blood flow, so we need that return of adequate circulation. We need the volume of toxic products released, cerebral edema, flow alterations. This is just repeating what was on the previous slide. So looking at this picture a little bit closer here, we have a clot that happened in this major penetrating artery. Everything that is black here in the middle is getting no blood flow. It will die. Everything surrounding it is reduced blood flow. So we have red, which is okay, orangish red, which means a greater loss of flow. What we are trying to do is we are trying to save all this area here. All this area here that has reduced blood flow is called the penumbra. It is what we are trying to save. As time goes on, this area of dead tissue, or this core where you had 100% blockage, this area of dead tissue can expand and get bigger and bigger and bigger as time goes on. That is what we are trying to do. That is what we are trying to do. We're trying to reperfuse the penumbra. This same sort of concept happens in an MI, and a myocardial infarction. They just don't give it the fancy term penumbra. Okay? All right? You don't see that word pop up anywhere in myocardial when we talk in the lecture of myocardial infarction. Why? Because even though the concept of reperfusion and why we're doing this is purely identical, okay, cardiologists don't like neurosurgeons, and neurosurgeons don't like cardiologists, so they make up their own silly terms. Okay? So you will have to remember this for your test, because they will use these terms in this way. A large vessel thrombolytic stroke. Would I ask this on a test? Damn right I would. I would ask you what a large vessel thrombolytic stroke could come from. It could deal with an internal carotid artery, vertebral arteries leading in, junctions at the basal and vertebral arteries, and any arterial bifurcation. Okay, most of the times they occur by a thrombus that is caused from atherosclerosis. a thrombolytic stroke. When you have a thrombolytic stroke, as we were talking about, where you end up having a clot, we have something called aphasia that can occur. This is what's called the ability to comprehend and formulate language. The ability to comprehend and formulate language is different than actually being able to speak. Right now, my ability to speak to you is perfectly fine. You can understand my words. But if you ask me what time it is, and I answer back to you, my dog is blue, then obviously there was an issue between the processing of my answer and what actually came out of my mouth. You can still understand my answer, but I'm not slurring my words. Here's the two differences. You ask me the question, what time it is. If I have aphasia, you'll say, what time is it? And I will go, my dog is blue. If I am slurring my words and I don't have aphasia, okay, and you ask me what time it is, and I say it's 3:30. That's the difference between aphasia and just slurred speech. Okay, the ability to actually say the words, okay, is not impaired, but my ability to comprehend and formulate language, my answer coming out the proper way, is, and that is aphasia. Neglect, we will talk about these terms. It's a general term that basically means they use it in saying, okay, you have a verbal neglect, you have a sight neglect, it's basically a way of saying what area of your functioning has been impaired. And they can use that term to talk about generally a number of different areas, and they can also say that there is what we call a unilateral spatial or even contralateral effect, neglect as well. Usually there are some sort of visual defects that will occur, and sometimes what we even call transient monocular blindness, which means just blindness in one eye, and then it sometimes will go away. Small vessel stroke. Here's one of those other pretty words that they like to use. Okay, lacunar infarct or lacunar artifact that will happen. These happen in the small penetrating arteries. Okay. And with these occlusions will lead, they're hard to get, they usually happen in the middle and posterior cerebral arteries, and what ends up happening, it's very hard to actually get to these ones, but because neurologists like to make up big words, they call it lacunar artifact. Alright? And a lacunar infarct or lacunar artifact leaves behind something called lacunae. Okay, lacunar, lacunae, tomato, I know. So these lacunar infarcts leave behind lacunae. These lacunae I think it's a French word. I don't know for sure, but it means small cavities or lakes. I know, little lakes is what they call it. Basically what happens is because it's a small penetrating artery, you're going to have a small area, like I showed you before on the previous slides, a small area that has dead tissue to it, okay? And then we say you have little cavities or little lakes of dead tissue in your brain after having a small vessel infarct or a lacunar infarct, okay? And the cause of these small lacunar syndromes can lead to a pure motor hemiplegia. That means, when you say pure, we mean that basically motor only. You're having trouble moving your arm. Or we can have a pure sensory hemiplegia, meaning I can move my arm, but I can't feel it. Okay. Now this one right here, for those of you who have your notes, please, there is an error here. This one here called dysphagia, it's incorrect. It should be dysgraphia. Okay. So dysgraphia is a weakness in one hand, especially when writing, so they have trouble actually writing. And we usually primarily use MRIs to diagnose these lacunar infarcts or lacunae that are left from them. Reason being is that we're looking for dysfunctional tissue that is happening within the brain. You rarely see those, we don't see those well with a CT, we see it primarily with an MRI. Now, remember I said there was a stroke that sometimes resolves spontaneously? This is called a transient ischemic attack, what we call a mini stroke. It's not a full stroke because you don't actually have, and here is the big delineating factor between a regular hemorrhagic regular ischemic stroke and a transient ischemic attack, or a TIA. The main big difference here is it's a temporary disturbance in cerebral blood flow, which then the infarcts reverse. So we're happening less than an hour, everything goes back to normal, and you have a full recovery. So with this one, you get a zone of penumbria without a central infarction, so a zone of penumbria without a core that got zero blood flow. Okay, so you just get reduced blood flow across the entire brain or entire area where that was leading to. But for some reason, the clot resolved by itself, and it was not long enough to actually cause any permanent damage. Lasting less than an hour, no permanent damage, or what we would say is no central core, no bullseye on the target, with 100% reduction of blood flow. It usually is caused by atherosclerosis that happens in some of the cerebral vessels, okay? And this is a warning that you're going to get an impending stroke. You start getting these TIAs, you're days or weeks away from having a major one, okay? So it's a warning sign. It's like a buildup. It's like, hey, we're about to have an avalanche and here comes some snow. Well, gee, the snow that's building up is going to lead to a avalanche, all right? That's the sort of way I sort of see TIAs. The snow before the snowfall, or the snow before the avalanche. Cardioembolic stroke. This is caused by a moving blood clot that goes from its point of origin to the brain. Most of the time, this is coming from the heart. The frequent site for an embolic stroke that we might see is the middle cerebral artery, where it gets stuck. And most of these start in the left side of the heart. Because you think about the left side of the heart, it shoots off into the descending aorta, but there's two arteries that shoot off from that major descending aorta that go up to your brain. So it's a straight shot basically for blood to get up into your brain from those, thrombus to get up from your brain from the left side of the heart. It has a sudden onset and has a maximum catastrophic effects. It's going to block off a whole section of your brain. These are the people who usually go, I think I'm having a, and then pass out on the ground. They don't sit there and go, oh, my vision is blurred, and oh, I don't feel so well, and and oh, and I'm starting to slur my speech. No, it's usually catastrophic. These are usually people who go unconscious from a stroke very quickly. Acute stroke manifestations, we usually end, so symptoms from a stroke or a TIA, so a major stroke or a TIA, are usually always sudden in onset. So that's one thing that both TIAs and strokes have in common. And the onset, they're usually focal and usually one-sided. Usually you don't have a stroke on both sides. If you do, you better make sure you have your will all in place if you're going to have a double one. And then what we usually end up seeing is some of these manifestations: weakness in the face, arm, sometimes leg, unilateral numbness, this thing called, oh my God, what is that? Just hold on. All of these terms right here, unexplained ataxia. Let me go to explain ataxia. Ataxia basically means difficulty in walking, or ataxia. No, ataxia is something in Toronto that basically steals your money, and crashes your car. A sudden unexplained ataxia is difficulty in your gait. Gait, in other words, walking. So all of a sudden you're limping and walking funny on one side and favoring one side. That is unexplained ataxia. Unexplained meaning, I was out late with the boys and my wife hit me in the hip with a baseball bat. Well, I'm walking funny because of that. I wake up in the morning, I've had no injuries, I've done nothing weird or funky in the last couple of days, and now I'm having difficulty walking. That is unexplained ataxia, and it can be due to a stroke. Now these other terms I'm going to talk to you about on the next slide. So here, now this is what you'll notice where I made a mistake in the previous slide where I said writing was dysphagia. No, dysphagia is slurred speech, okay? And aphasia is that language disturbance where I cannot formulate language. Ataxia is a gait imbalance. And as I said, the previous one would be dysgraphia, which means I have trouble writing. Hemangiopia basically is loss of vision to one side of one visual field or another. And I'm going to explain visual fields. Not that I'm going to test you in depth on what visual fields are lost. I would never do that. But I want you to know what the term is and what a visual field actually is. Okay, and then we have this big funky sort of word here, Amorosius fox, which is basically vision loss in one or both eyes. So this means vision loss in both eyes. This means loss of a vision field. And you're probably saying, what the hell does that mean? What's the difference between the two? Let's go to the next slide. This is what a visual field. So this one here, this is complete loss of all vision in one eye, correct? Like this is not your eyeball, okay? If I was looking straight ahead, okay, or this is a 360 degree field of vision of how I can see. So my peripheral vision, the visual in my front, the vision to the sides, vision right dead center ahead of you. Look over here on this diagram right here. This is a representation of this. Your visual fields. I can see I have peripheral vision this way. I have a main visual field here in the middle. Okay, I can see I have peripheral vision off like this. This is a representation of what's happening in this visual field right here. If I have complete blindness in one eye, that means that all of this, my peripheral vision and all this vision here, is gone. Okay? If I go down one here and say that same thing on the right eye, I just have a loss of vision, or hemianopanolia due to the in my field of vision. That means that if I closed this eye sees fine. Okay, let's just actually I'll speak of all. Let me jump down to number 3 here. Number 3, we'll go number 3 and number 2. It'll be a little bit easier progression for us to do. Let's go down to number 3 right here. We're saying that the left eye is fine. So this sees everything. If you were to close this eye, you would have full visual fields from the left. Number 3 here. Left eye is fine. Right eye, let's close the left eye, put a patch over to whatever, and let's just look through the right eye. What would you see? You could only see things here and your peripheral vision. You would only see this area here. You would be blind in all this area right here from your right eye. So literally, like right down the center, I could not see anything in my right eye over to from the middle of what I'm looking through my right eye to the left. And it's not a clear cut. It's not like you're looking at a TV screen and somebody's done a split screen at you. There would be a fuzziness to it. Okay, so you're basically saying if you look through your right eye right now, you can see some things over on the left-hand side of your nose. If you close your left eye right now, look through your right, you can see some things from the middle of your nose over to the left. Okay, okay. So right now, this is what I'm doing in front of my screen right now. I'm closing my left eye. Put my hand straight up and down, up to my nose. Now move it 1 or 2 feet away from my nose, and now move it off to my left. You can still see your left hand right now, can't you? Yes. If you had this situation happening right now where you had lost the field of vision on the left-hand side of your eye, of your right eye, you would not be able to see it at this point. You would only be able to see things that are directly in front of your nose and to the right. So that's where you start losing specific field of visions. Okay, if we had that happening both eyes, where the right side was gone, this is where you could not see anything to the far left or far right of your eyes. Okay, and it would be happening in both eyes as well. So I would never expect you to do this in for testing purposes, but I want you to be aware that of those 2 terms we looked at on the previous slide, one is a complete and utter blindness that is occurring in one eye. You can't see anything through it. And the other term refers to partial losses of fields of view for one eye or the other. Okay? And these are what these fields of view look like. And it can be very distinct if you're looking just through one eye. Okay? That's enough. You also have a citation down here. Since I'm not going to test you on this, at least you know this when you're seeing it, and know that there's a difference between the 2 terms when it comes to testing time. Diagnosis of an acute stroke. CT, number 1 thing on the hit parade for us to do is a CT. So the reason why we do a CT is there is a difference between a CT and MRI, and the number 1 thing is this. you're starting to have symptoms of a stroke, you don't know which kind of stroke it is, do you? You don't know if it's a hemorrhagic or an obstruction, do you? How do you find out? Well, you don't want it to be, if it's a bleed, you need to go to you're going to go to the operating room quite freaking quick. Like, I mean, now. If it's not a bleed, you got a little bit more time, but you have other options to actually recovering or reperfusing if it is an obstructive stroke. That are not as invasive. We can use thrombolytic therapy. We can use balloon therapy. Similar stuff that we saw when we were talking about an MI. But we go for a CT right away. MRI gives you more information. It tells you what tissue is perfused, what tissue is not perfused. An MRI would show you a penumbria. Okay. A CT would not show your penumbria. An MRI will show you which tissues are being perfused and by how much. A CT would not. So why do they always tell, let's go for a CT immediately when you have a stroke? Two things in particular. The first thing is a CT is effing fast. Okay? I can have you up in a CT and have a full image of your brain within 15 minutes. And what are we looking for there? I just told you that a CT is not going to tell you the difference between perfused tissue and non-perfused tissue, did I? What will it show? It shows bone, it shows brain tissue, and it shows blood. If I see that if you're having a hemorrhagic stroke, you will have a collection of blood somewhere in your brain. And I will be able to see that. So, what we do is we diagnose you quickly, okay? We diagnose you quickly with a CT to make sure, or we use the CT to rule out a hemorrhagic stroke. And then once we rule out it's a hemorrhagic stroke, great. If it's a hemorrhagic stroke and we can see blood on a CT, they basically take you from the CT into the freaking operating room. Don't pass go, move your butt. Okay? If it is not a hemorrhagic stroke, we look on the CT, all we see is brain tissue, we see bone, we don't see any blood. Then what we do is we jump down to do some vascular imaging to find out where the stroke is. We have a little bit more time to play with when it is a ischemic or an obstructive stroke. So we have a little bit more time. We go to CT angiography. We might even choose to do an MRI at that point and find out exactly where the clot is so that we can go in and decide what best therapy to do. We have some time, remember, several hours. And why I said with a hemorrhagic stroke you want to move faster, I will get to in the next couple of slides. But this is why we do it. We basically we rule out hemorrhagic stroke immediately. Okay, and then we do some other imaging to try and figure out what to do next. And the MRI as well, the other reason too is when I said CT is fast, 15 minutes, it takes 20 minutes minimum to do the scan for an MRI, up to 40 minutes to an hour. More likely 40 minutes to an hour once they turn on that scanner, and that's how long it takes for an MRI. For a CT, I get you up to the scanner, I stick you into the scanner, I strap you down, and within 5 minutes, bing, I have an image. Okay, it's that quick. So yes, we are using, it's not as precise as what we would want to see. It doesn't show us all the different things as MRIs, but it takes too long. And we need to rule out those sort of things. And once we have you on a CT and we go, hey, you know what? We figured out it's not a bleed. Fantastic. Well, let's give you some contrast, do what's called a CT angiography, find out where the clot is. Okay? So that's why we do the CT. Okay? And then we can also use there's some other things, but most of the times we use a CT and CT angiography. Do the CT first, no bleeding, fantastic. Throw in some contrast into your bloodstream, see if we can find where the clot is, and we basically map all your blood vessels in your head. Works very well. Treatment for an ischemic stroke, well, as we said, our main thing is here to try and salvage the brain. We want to prevent any secondary stroke and minimize the long-term disability. That would be rehab. Reperfusion we can see is thrombolytic therapy, so anti-clotting drugs, and if you have a hemorrhagic stroke and you give TPA or that streptokinase, that clot-busting medication, that thrombolytic therapy to somebody, you give that to somebody who has a hemorrhagic stroke, you will kill them. Okay? Because that brain is probably trying to make clots and has probably made some clots to reduce the bleeding as much as it can, and now you've just opened them all up. It would be like it would be like Niagara Falls of bleeding happening in their brain. So thrombolytic therapy is not to happen when you have a hemorrhagic stroke. It only happens when you have an ischemic stroke. So catheter is then directed. Sometimes catheters can be directed in, just like we saw with the MIs. Can go in balloon dilation. They can actually disrupt the clot or actually open up the artery. And sometimes there can be some augmentation of cerebrovascular perfusion. This doesn't happen that often, but usually we see that these are the first two things that they do. Post-stroke management. The risk of a stroke occurrence is highest within the first week after a stroke or a TIA. Early implementation antiplatelet agents, and we're talking post-stroke management of a ischemic stroke. Early implementation antiplatelet agents, warfarin is one of the other ones, specifically in a cardioembolic stroke. And we want long-term stroke reoccurrence prevention with prevention of those risk factors. So not only getting and putting you on antiplatelets and sending you home on warfarin, but we want to make sure that you're not eating burgers 3 times a day, and that we get your hyperlipidemia under control. Early hospital care, usually we have to have the prevention of a couple of following things. What did we say that a stroke could possibly do? Stroke could possibly fool around with your slurred speech, which also means your ability to swallow. So you have to be very careful in the first early days that people do not aspirate because they're having difficulty swallowing. DVTs can occur because, well, guess what? If you threw a stroke because you're making clots, when you can have DVTs, that means you're at risk from other peripheral vascular, cardiovascular disease, and falls. Why? Well, we just said that you could have gait problems, right? And that those will be slow in returning back to normal. So they could get up and they could fall if they have an issue with their gait. These are 1, 2, and 3 of the things that you have to be careful for when you're taking care of a patient post-stroke. Hemorrhagic stroke or bleeding. Okay? So let's talk about hemorrhagic right now. So we bent back. This is the same diagram I showed you before, and look. Basically, we have what looks like an aneurysm or bulging that happens in the blood vessel, and bleeding occurs. Notice where this is, and notice what's happening that's different in this diagram. Before there was a clot here, and yes, there is a reduction of blood flow happening up here. It just doesn't show it that well on this diagram. But where does the blood go? The blood goes in all this space here and around the skull as well. So what is happening when you put blood into this space around the brain? Well, it's coming out of a tube which is under high pressure. It's going to continue to bleed into this space. What do you think that increase in pressure is going to do? Squeeze your brain like a sponge, and when it squeezes it, it will reduce the ability for blood to perfuse through it. So not only are you losing blood flow to this big area of the brain here where this breakage happens, but guess what? As this fills up with blood and squeezes your brain over this way, guess what else is going to happen? Decreased perfusion over here, decreased perfusion down here. Why? Because this brain tissue is being squeezed like a sponge because of the increase in blood filling up this area. Believe it or not, the blood coming from your heart is under is under enough pressure that it can squeeze your brain. Your brain is the consistency of a sponge, or jello, for lack of better terms. It can be squeezed and crushed by increasing accumulation of blood from a high pressure hose. That high pressure hose is basically your artery. Okay, so this is where I said with a hemorrhagic stroke, it's a double whammy. Okay, not only are you losing blood because blood isn't getting down this pathway right here, but that blood that is spilling into the spaces around the brain is causing an increase is filling up a volume of space and squeezing the blood out of other brain tissue that was not affected by the burst. Okay, so it's a double whammy. This is why when we find these things, it's a one-way trip to the OR. if it's in a spot that they can actually operate it on. You can imagine if you have a bleed down in this area here, which area would it be able, which area is easier to get at a blood bleed? Maybe over here, because I can rip off your skull, go in here and drain off whatever blood fluid is there and clip off that artery. What happens if the artery is burst down here? I have to dig my way into here through your brain and try and clip it off. Very hard to do. Okay? And when I take off your brain, when I take off your skull to get at that tissue, or to get at that vessel, what is it going to do? That bleeding is going to force brain tissue out through the hole. Very much harder to get at bleeds that are happening deep within the brain tissue. Okay? Much easier to get at bleeds out here on the surface. Which leads us to the next two slides. So hemorrhagic stroke, most commonly fatal. Okay? Rupture of a blood vessel usually results in the following, which I just described. An expanding hematoma or an expanding blood clot. And that expanding blood clot squeezes the rest of your brain. We end up getting tissue edema and compression of the brain contents. Most common are due to aneurysms that are somewhere in the brain, and one of the most common is what we call an aneurysmal or subarachnoid hemorrhage, or a SAH. Or we can have an intracerebral hemorrhage as well. Most common risk factors: advancing age, hypertension, and then aneurysms, trauma, tumors, AVMs, which are basically a malformation where you have veins attached right into arteries with no tissue between the two of them. So it's really an aberration or a malformation that happens. It's like a birth defect. You're usually born with AVMs, or atriovenous malformations. And blood coagulation disorders can cause this, well, vasculitis, basically anything that is going to irritate a blood vessel to the point of it bursting. Okay, drugs will cause that as well. Manifestations of a hemorrhagic stroke: vomiting. So this is where it is different than a obstructive stroke. We see that vomiting and a sudden onset of a headache is more commonly seen with a hemorrhagic stroke as compared to a obstructive stroke or an ischemic stroke. We usually see a contralateral hemiplegia and an initial flaccidity, meaning that the arm or the leg on the side that we're talking about goes flaccid. It's like flops all over the place. And then it will progress to progress with spasms in it. So it starts with flaccidity and then progresses with spasticity. And this is usually due to a hemorrhage somewhere in the basal ganglia. And the resultant edema exerts pressure on the brain tissue, causing a progressing rapidly to a coma and most likely death. And this is due to something that you're going to see even more so next semester in semester 3, called the Monro-Kiley hypothesis. What this hypothesis is it's kind of common sense, but people don't see it that way. If you think of your brain is your brain is a big bowl with a small entry port through it. It's like take a 2-liter plastic pop bottle and flip it over. Okay, that is your brain. That is your head. Inside is jello. Okay, and the plastic bottle around it is your skull. So what we say that the cranial compartment is incompressible. That means you cannot change your skull. If pressure starts to increase in your skull, guess what? The skull isn't going to give. So the volume inside the brain and inside the cranium is a fixed volume. You cannot, if you try and push more of one thing in it, like an expanding blood clot, something has to give. Something has to compress, or something has to go somewhere. And what we usually end up seeing is the brain is usually is more of the softer of the tissues that are occurring here, and under least pressure, it needs to be perfused. It will end up getting squeezed. Okay? So the Monro-Kiley process says that if you increase the volume of one constituent, it will affect the rest of the constituents. They either get compressed or pushed out. Okay? So we usually end up seeing the cranium, as I said, and the constituents are CSF, brain tissue. These are at a state of equilibrium. We also see that down through your spinal cord because that fluid and everything is continuous with your spinal cord. The meninges that is around your brain is continuous with the meninges that go around your spinal cord as well. And we see and the spinal cord or a lumbar puncture and the pressure that's in your spinal cord is a good representation of what's going on in your brain. So any increase in the volume of one constituent must be compensated by a decrease of a volume of the other. That's all it's saying. You can't shove any more water or fluid into that pop bottle with jello, or what ends up happening, the jello compresses or the jello will, unfortunately, come out. Okay? And here's the jello coming out. So we have two issues happening with this brain right now that could cause compression. We have a situation here where we have a bleed going on between the skull and the brain, and look at this right here in the middle. This is your spinal cord. There should be a straight line going up the middle right here, and this fissure right here should be in perfect alignment with your foramen magnum. It's not. It has shifted over to this side, and this is shifted downwards. Why? Because all of this blood that is being pumped into this cavity is crushing your brain, okay? To the point where it could even do the following, okay? Here is the inverted pop bottle. Here is the jello inside the pop bottle. Now I stuck a tube inside the pop bottle and I start blowing in fluid. Guess what happens? Pushes out the jello, and can even push the jello down through your foramen magnum. That happens, it's game over. It's called a brain herniation, and you're done. Okay. The other thing that could happen in this situation here is if you have an open skull fracture. Okay, so in this situation here, we have brain tissue being pushed here. And let's say that part of your brain actually got broken, or part of your skull actually broke off. Well, it would actually push your brain out through this opening here. So if this was continuous, let's say you didn't have a big skull fracture where there was an opening in your brain, the only place for your brain to go is down through here. Okay? In this situation here where we have a bleed and an open skull fracture, which means part of the skull is missing, then the brain will be pushed out this way and down through here. Not a good situation. Okay, so subarachnoid hemorrhage. So we're not talking about a bleed happening here. We're talking about a bleed happening over here. I just have this diagram because it's a cool diagram. But we're going to talk about where a bleed happens over here on the surface, not down over here. So subarachnoid hemorrhage happens. Look at this subarachnoid space. You have your skin, your scalp, your bone of your skull, and then the meninges underneath, and then you have this space in between the brain and all of those layers, and that's where the blood vessels are. And this is where, if you have a bleed here, it's much easier for us to fix something that happens here than way deep down inside in your brain. Okay? So it usually occurs to an aneurysm, bulge at the site of weakness in the muscular areas of the wall. It can arise from a congenital defect or a trauma. Rupture usually is the leading cause of bleeding. Rupture of an aneurysm is usually the leading cause of bleeding, and leading to increased intracranial pressure. That's from that Monro-Kelly process. Increasing intracranial process starts to crush your brain. Etiology can happen from congenital abnormalities, can cause from other ones, atherosclerosis, so you can have a weakness. You can have a weakness in the area. The atherosclerosis can lead to a weakness as well in those blood vessels and aneurysms. Hypertension can cause aneurysms. Bacterial infections can actually damage and thin the arterial walls. And the incidence of rupture usually happens commonly between the ages of 40 and 60. Yay, I'm right there. Probability of the rupture increases with the size of the aneurysm, and often the rupture occurs with acute stress and increased intracranial pressure, such as straining with stool. So sit down and try and push out a constipated one and you've got an aneurysm in your brain. Yes, you could burst a blood vessel and start to bleed. Greatest lifestyle risk factors are smoking and drinking. So not only can you not go to the bar, but you can't have a smoke at the bar. Manifestations before the rupture, and this is usually they are asymptomatic, but there is usually a history of atypical headaches, because it's almost like it's a slow bleed sometimes, even before the bleed gets worse. So sometimes they will get headaches and maybe some vomiting several days to weeks before a full rupture occurs. A large rupture will have a sudden, will have a chronic headache, big neurological deficits as well, and will be accompanied definitely with vomiting and dizziness when you have a large rupture. So that's where it's very different when we have these strokes that are hemorrhagic as opposed to an obstructional stroke, which is an ischemic stroke. Those ones, big difference between the two that you've seen right now, vomiting and nausea. Okay, the vomiting and nausea is different, right? And that's usually due to changes in ICP across the brain. Most common manifestations after a rupture, okay, severe headache, okay, bleeding causes a collapse and loss of consciousness, and vomiting. Another thing, nuchal rigidity. This means you have a stiff neck. No, it doesn't. Okay, stiff neck is very different. I can have a stiff neck if I go out and play a bad game of basketball and jerk my neck. That's a stiff neck. Nuchal rigidity means that if you're unconscious, lying there on the floor, and you have nuchal rigidity, and I grab your head and I try and flex it backwards or forwards, I would have trouble moving it. It would be that stiff. Okay, that is nuchal rigidity. That also happens with meningitis, which is number one thing when people say, my kid has a sore neck. Oh my God, they might have meningitis. Can you look up? Can you look down? Can you look left? Can you look right? It's not meningitis. Go away. Okay, so that is what we call nuchal rigidity. That occurs in meningitis where there is change in ICP. And you see this as well in a hemorrhagic stroke where there is a change in ICP going up. Okay, if you haven't figured that out so far, the ICP is going up. And we see that nuchal rigidity happening because of that. We'll see some photophobia, double vision, blurred vision, some focal motor and sensory defects. These ones are more like what we would see in a regular stroke, right? We see some cerebral edema, increased ICP very quickly, and we see some hypertension happening as well. Okay, so we see some differences right here between a ischemic and a hemorrhagic stroke. Diagnosis of the SAH, clinical presentation. Okay, what's happening to you? We do a CT scan, as I just said, because we want to rule out that it's this, or if it's not this, it's an obstruction. They can do some vascular imaging tests, similar to what we did before with the ischemic stroke, cerebral angiography and CT angiography as well. You might even do a lumbar puncture. Well, you know what? Once you've done these three, you really don't need to do a lumbar puncture, but it could still be done in very odd, rare cases. Treatment depends on the extent of the neurological deficit. Best outcomes achieved when the aneurysm can be secured and complications prevented. Okay, so this means going in and clipping it, tying it off, doing whatever. Mild to no neurological deficit may undergo cerebral angiography or an early surgery. So if you get it early, you have a bigger chance of not having any deficits. There are these things, so you can go in and clip it, which basically means taking off part of your skull, finding the SAH, going in and clipping it, okay, sewing it off. Endovascular techniques, this means actually approaching the bleed from inside your vascular system. So this is where they will put a tube in through one of your arteries, take it up to the point of where the bleed is, and they can do something called a balloon embolization, which basically means almost like cauterizing the bleed and actually and causing the clot to happen where you want it to do in the bleed. Okay, two different ways of doing it. This is why they do the CT angiography, to figure out which one is best to do. Complications. Now the complications, yeah, would I ask you the difference of the complications between this and a ischemic stroke? Yes, I would. Rebleeding can occur within the first day after a rupture with further devastating neurological effects. Vasospasm with cerebral ischemia can happen. So vasospasm is actually the arteries actually contracting uncontrollably and then causing ischemic events to occur, not due to a clot, but because of contraction of those blood vessels. So it's like having a huge muscle spasm. Hydrocephalus can occur, and we can also see hypothalamic dysfunction occur as well. Okay, so as I said, hydrocephalus and hypothalamic dysfunction. So this means if you have a aneurysm rupture that actually services your hypothalamus, that you could actually have damage happening to your hypothalamus. Seizure activity can occur, and in the worst case scenario, you're dead. Okay. Vasospasm. The one thing about this, and look at when this can occur. Now, there's some differences here between a ischemic stroke. And would I expect you to know the differences between the two? Damn right I would. Okay? What did we say about ischemic stroke? There's a high risk for having another ischemic stroke within 7 days, right? Yes. With a hemorrhagic stroke, highest risk of rebleeding within 1 day. And within 3 to 10 days of having a hemorrhagic stroke, high risk of having vasospasm. You need to know this because if you are treating these patients in a medical surgical unit, this is what you have to be careful of. They've come to you from the ICU. This is what you're looking for, and you have to be aware of. Okay. So vasospasm, as I said, is basically having those arteries contracting uncontrollably and causing ischemia happening. It usually involves a focal narrowing of the cerebral arteries, and you end up getting deteriorating neurological status as the blood supply decreases in the area of spasm. If you hear some thumping in this presentation, those are my daughters being idiots. Treatment of the vasospasm. We need to maintain adequate perfusion through use of vasoactive drugs. So the problem with these vasospasms, they're very hard to treat. We have some vasoactive drugs that we can use. We can use large amounts of intravenous fluids, which can try and forcibly expand open the vessels. But there's a high risk for rebleeding that can occur with this as well, and it's really a problem. Okay, these post issues can really cause issues. So we can also use early surgery is the number one thing, and we can use balloon dilation to help actually open up those vessels if you know exactly which vessel is spasming. One of the medications that they can use, I won't ask you specifically the medication on the test because that's pharmacology, but if you come across it in clinical, it's nimopidine, which is usually one drug that blocks some calcium channels and can help them actually dilate.